Hi, we're back. This is Gerald Major with hashtag See Arthritis at the Canadian Rheumatology Association Allied Healthcare Professionals Annual Scientific Meeting in Montreal. And it's a pleasure to be joined with Dr. Gilles Boire. And I will let you actually introduce yourself and talk a little bit about your involvement in rheumatology and the CRA.
Okay. Well, I'm an academic rheumatologist. I'm working in the University of Sherbrooke and the University Hospital there for the last 30 years. I'm the proud father of 3 girls and a grandfather too, many times, 5, soon to be 6.
Excellent.
And I practice rheumatology both with kids and adults for the last 30 years, as I said. And I combine teaching with research and clinical activities.
Excellent. So you are in both the pediatric and adult.
Yeah, well, it was a necessity when I came in Sherbrooke. There was no pediatric rheumatologist, so I took over. I'm an adult trained rheumatologist, but I took over the clinic of pediatric rheumatology, and with time, I think I learned quite a lot about that.
Well, I mean, you're as I meet more and more people, there's it's not so rare, I guess, but how important it is for those people that transition, like transitioning between pediatrics and adult, 5 years ago looked much different than it looks now. And I would imagine it's because of people like you that are able to see both sides.
Yeah, I think it's, in our case, in Sherbrooke, the transitioning is not a problem because I treat some kids for 25 years now.
Right.
And they come with their own children.
What are you noticing? So my journey began at 14 years old in 1986. Obviously, for ankylosing spondylitis, it was 19 years before biologic medication. What do you? So really, I was a juvenile arthritis case.
You are.
Without the system back then, or I mean, I didn't end up in a system like that. So. What are you seeing as the benefits to children nowadays, as opposed to, my story?
Well, it's. I would say there's a lot of improvement. First, because we can see those kids much sooner, and when you act early, especially with axial arthritis, you can prevent a lot of complications, fusions of vertebra and other things that are almost, although some kids come already with some damage in the spine, but it's not comparable to what we see in adults, for example.
It's nice to see that there's been recent funding around pediatrics and pediatric care. I personally think that it's much needed, so it's really nice to see. But we've been hearing, and last year I was interviewing a few, and we were hearing back then that there's research starting and being completed around being able to maybe use multiple doses of a biologic and stopping the condition. Where have we gone in the last year on that?
We still need to know what to use, and it's not every patient that will be able to stop. We're still waiting for that, I would say.
Okay. But, I mean, progress.
Yeah. I think it's, if we can control the disease when it's most active, in the first few years the arthritis tends to be most active. If we can control it during that period, sometimes we need, I wouldn't say we see the disease disappear, but it becomes easier to control on the long term. And so in some patients we may be able to decrease the doses and possibly in some stop effectively.
Yeah, and I mean, in my case specifically, my case is interesting because it happened at a time when there wasn't really medication. And so then, you know, my frustration sometimes goes to that. I mean, I can tolerate the fact that by the time I left work and was taken out of work, I had 9 surgeries lined up to do. And they were built in the 80s and 90s of all the damage that I was having, which is all the more important to diagnose early and treat early in today's environment. Because like you said, I think that all of my surgeries were built up because of the damage over the years, and you know, treatment alone does not get rid of disease.
No, unfortunately.
And so, you know, you have to continue to have, you know, proper diet, exercise, and I guess let's talk a bit about the psychosocial aspects of rheumatoid or of any inflammatory, any arthritis, really.
Well, we did look at psychosocial determinants such as depression, anxiety, coping with disease in patients with early inflammatory but peripheral, mostly rheumatoid arthritis patients. And we found that those were the most important factors to explain the persistence of disease activity over time. In fact, most of these patients we could have a control of the joint inflammation, at least clinically, but in those patients we still had. It's difficult to say if it's the chicken or the egg, but in those patients who still have depressive symptoms, for example, a few months after the full impact of the disease, of the treatment of the disease, those patients are much more likely not to evolve positively over the next 5 years. It's what we found, at least in rheumatoid arthritis patients.
So you're identifying a link between depressive state or depression and an overall outcome?
It depends in a way, because the way we measure disease activity in RA is very significantly determined by how the patient appreciates the disease, how he evaluates the disease activity himself. So if there's a strong correlation, or moderate, I would say, correlation between the depressive symptoms, the anxiety, the pain, and the fatigue, and how the patient appreciates the disease activity too.
So,
and I think what we are doing now is doing a trial of offering in those patients. There's a disconnect, I would say, between the objective and subjective symptoms. We offer an intervention. It's what we use is mindfulness-based stress reduction. The first results are very encouraging. But I think other interventions would be possible, like cognitive behavioral therapy and other things. But I think that the earlier these symptoms can be recognized, first we must control the disease, but then if the symptoms persist, I think we should offer rapidly those for the best outcomes of the patients.
So it sounds like within your practice that you recognize the mental health component of illness right away. And then you're waiting for it to appear before discussing, like, how do you, so across the board physicians right now are not aligned on the mental health
Yeah,
conversation, as far as I'm concerned.
Well, it's some physicians prefer not to know
Right.
because it's difficult to act on that. I think the interventions have to be sequential. At first, when a patient becomes very ill, very
Right.
inflammatory, the patient doesn't need to have his depression addressed or have intervention on that. He has to have a control of the
Right.
disease.
Right.
Because when the arthritis is very active, it's a majority of the patients who will have depressive symptoms.
100%. Yeah.
It's very it's easy to understand. But once we have a good control of the disease, and then we should intervene at that time. Yes, the sooner it will be done, probably the less loss of work or
Right.
other consequences will appear.
I'm so happy to hear that you're addressing this. I mean, you're doing pediatrics, you're doing adult, and you're addressing psychosocial aspects of things. So I would consider you to be doing it all right now. So how do you afford the time on this?
Well, I'm an academic rheumatologist, as I said, so I'm not in clinics all the time. And I can have some help also from other, we are a group of rheumatologists, and we have some help with a nurse and other people like that. So, but I mean, it's not, time is very important, I know, but if you spend time at the right moment, it has a much significant impact over the years after that. So defining when is the time, it's time to discuss about that. It's I think you need a few minutes to decide if you do that.
So this year's theory at the CRA is building bridges. So what does building bridges mean in your work?
Well, as I said, I'm working mostly in early inflammatory arthritis, both clinically and also in research. So building bridges for me is trying to make sure that the information is shared. I'm sorry, sometimes the words don't come easy because
they're beautiful. I mean, no, they're beautiful. I have no issues with it at all.
Okay. So sharing of the information, I think the patient must be at the center of that sharing also. He must know in advance how the things should happen. He should know that sometimes there are problems. We can have to modify the medication. It's not a one size fits all. It has to be. So that's one way. And the other way we work on building bridges is, as I said, we try to combine the definition of biomarkers with patient-related variables like depression and everything, and trying to define a better mix that will best fit or describe the patient and describe how we should intervene in that patient.
I'll go on. Anything from our viewers, Anita?
Yes, there is. Can you recommend resources for parents of patients to cope with the psychosocial component when their child is diagnosed?
The problem is the availability, but for kids it may be a bit easier than for adults because there are, at least in our area, there are more resources, psychiatrists, but it's very difficult. I would say there are a number of resource groups of that may combine group of parents, for example, you may find, but for the psychosocial, I think it has to be defined for the patient individually. It cannot be, addressed because there are a number of different problems. Some it's anxiety, or it may be other things. So it has to be decided on but the resources are, I think, available in the community for kids at least. It's easier, a bit easier, I find.
Okay, 2 more questions. Should patients tell their rheumatologist if they're experiencing mental health issues, or should they directly go to the other resources such as seeing a counselor?
Well, I would say I think it's important for the rheumatologist to know about that, because sometimes we're not trained as psychiatrists, but we see a lot of people with pain, with chronic disease, so we usually develop a sensitivity towards that, and it may be helpful either to address some of the problems that contribute to the problems, that the mental health problems, that, and at least, and it's usually we know people who can orient you to.
Okay, last question to close the interview. Do you have any lifestyle tips for patients living with arthritis?
Living with arthritis, I think it's very one thing that is trying to be equilibrium. You need to balance things. It's not easy, but you have to do exercise regularly in the limits you can do, but go to those limits. It's very important not to lose your capacity. Rest, also share with people around you. It's sometimes because people are in pain, or they try to retire and don't mix with other people. I think it's very important to share, to collaborate, and to discuss with the others.
Are you someone that takes advantage or sees value in the work that patient groups provide?
In the works that patient...
So the patient groups that we have in arthritis, this is the consumer group within the Arthritis Alliance of Canada. So where do you see, I mean, I see a ton of value in the psychosocial, but what value do you see patients receiving from other patient groups?
In our area, in Sherbrooke area, the only it goes through the Arthritis Society, and we have personnel that from the Arthritis Society that comes in our pediatric clinics and tries to really make connection between the. Apart from that, we don't have much, organized patients groups like that in our area.
I'll send you that, and you can have a look. So. It's been a pleasure, Gilles. Thank you so much for what you do and your work in our community. It's a pleasure meeting you.
Thank you.
Thank you.